Good morning. Welcome to the Sunday TEE breakfast session. This is being conducted under the Forum of Cardiac Anesthesiologists, which is also the Bangalore chapter of Indian Association of Cardiothoracic Anesthesiologists. Thank you for joining us. Today we have Dr. Sanjeevani Inamdar, who does not need any introduction to cardiac anesthesiologists and echocardiography enthusiasts. She is very well known, and the most striking feature of her academics is that she correlates clinical features, transthoracic findings, and transesophageal findings, and gets best of all the three and makes an appropriate assessment and diagnosis. If you take the technicians, they just do the technical job. They have no clinical correlation. Cardiologists do the TEE, but they do not correlate with TEE. But here we have one person who can correlate clinical findings, transthoracic echocardiography, and integrate with transesophageal echocardiography to the best possible interpretation and care of the patient. So I request Dr. Sanjeevani Inamdar and present her to you. And the topic is Doppler Reconstruction of Hepatic and Pulmonary Veins. And I think that we have a lot to learn in this subject. And I request Dr. Sanjeevani to go ahead with the presentation.
Then mute your mic, ma'am.
Mic is muted. Yeah, no, it's.
Thanks a lot, Dr. Muralidhar, for those wonderful, wonderful words. Sometimes we don't recognize us, but some people, like you analyze it better. And I'm really blessed and privileged to be here. I love this platform. I learn quite a lot. I'm attending this Narayana Rudayalaya breakfast session with utmost sincerity. Really I'm learning quite a lot, and it's a very good endeavor which you have started, and you need divine power to continue such big things. Thanks a lot.
Thank you for that.
Should I share my presentation, Rajiv?
Yes, ma'am.
Yes, please.
Sorry for that. Today we are going to deal with these two humble veins, which are pulmonary vein and are you able to see my slide in presentation view?
Yes, we can see it. It's
okay.
Clear.
Okay. So these are two humble veins which are even in this 2022, they are important. Along with the advent of strain, speckle and tissue Doppler, they have not lost their place. On the contrary, they are coming in a big way. We would be studying hepatic and pulmonary veins, and I would be speaking about anatomy and physiology in few minutes, and then we'll go to the clinical scenario. So hepatic vein, we all know that it drains to right atrium through IVC, which ultimately drains into right ventricle. This is the transthoracic subcostal view showing right atrium, IVC draining into right atrium and hepatic vein, which is very, very good for Doppler interrogation. It is the flow is absolutely parallel. Okay. And coming to pulmonary side, this is the left atrium and with 4 pulmonary artery draining into it. And this is the suprasternal crab view of transthoracic. This is beautiful view which shows all the pulmonary veins. Right upper, right lower, left upper and left lower. So in short, this is the transthoracic view again, subcostal view, how the blood flows. I have just shown you. It starts from here, goes to RA and goes to right ventricle. And similarly on the pulmonary vein side, this is the 4-chamber view where this is the right superior, sorry, this is right inferior pulmonary vein, which is going to left atrium, and blood goes from left to left ventricle, left atrium to left ventricle. See, one has to understand this flow pattern, and then one can analyze how the things are different in physiology and pathology. So these are the atrial waves. They are more or less similar on both sides. And let us start with atrial contraction first. You have to start with something in this cardiac cycle. So let's start with atrial contraction, where atria contracts vigorously and the blood is pushed into the ventricle. When blood is pushed into the ventricle, the tricuspid valve closes and mitral valve on this side, and there is a systole of both the ventricles, and the atrioventricular valves are pulled towards apex. So what happens? There is X descent on this wave, on these atrial waves. So this X descent, because of this sudden pulling and contraction of the ventricle, there is reduction in the atrial pressure, atria relaxes, and then there is flow starts from IVC, hepatic vein, towards the atrium, and on this side pulmonary vein draining into the LA. And this X descent is responsible, which is the ventricular systole, is responsible for the forward flow in hepatic vein as well as pulmonary vein, which is known as S wave. When the ventricle ends, there is again, it starts relaxing. When it starts relaxing, there is another wave which is a Y descent in this atria, and because of this the diastole starts. Okay, so in this diastole there is a reduction in the pressure over here. So again the flow is continuing from IVC, hepatic vein and pulmonary vein towards atria. This is typical diastole, which we know that initial reduction in the ventricular pressure. When there is reduction in the ventricular pressure, atria are also relaxing, and then the drainage of well, which is responsible for the D wave on the hepatic vein as well as pulmonary vein, and which is followed by the atrial contraction again. So if you correlate this with the pressure curves in the ventricle, and this is the hepatic and pulmonary, this is hepatic, let us say hepatic first, and pulmonary is more or less the same, and which we have to correlate with the forward flow during diastole across the atrioventricular valve. Here it is shown in tricuspid valve. So whenever there is atrial contraction, there is atrial reversal wave in the hepatic vein. Just correlate this with the atrial waves and correlate with the right ventricular pressure curve. So this is the forward flow during systole. This is forward flow during diastole, though it is less because there is no vigorous pulling of the atrioventricular valve towards apex. So this flow is smaller than S, followed by again atrial reversal. This is a very important concept. If you understand this, or if you remember this whenever you are doing cases, you will come across so many beautiful abnormalities. You can guide the surgeon, you can manage the patient very well. So when this diastole, this is the diastole, is correlating exactly with the E wave of the forward flow across the atrioventricular valve, and this atrial reversal, that is powerful atrial contraction causing backflow towards the hepatic vein, which is responsible for the negative wave. See, this is seen in transthoracic and this is seen in transesophageal. It is exactly opposite. That you remember, please, because otherwise one gets confused. So this AR is very meticulously, it coincides with the atrial flow across the atrioventricular valve. So one has to remember that this is the diastole and E and A coincides with D and atrial reversal. This is the important concept. If you remember this, things will be very easier. So this is a normal hepatic vein. Are you able to see my video? Hello?
Yes, ma'am.
Yes, we can
Yes.
see.
Okay. So this is typical video showing a normal hepatic flow, and it is against the probe direction in transthoracic, and in transesophageal it is towards the probe. So it is red in transesophageal and it is blue looking over here in transthoracic. So let us see the effect of respiration is very important because this is a right-sided low pressure chamber. So whenever there is inspiration, there is increased flow because of increased flow across the IVC because of reduction in the transthoracic pressure. And during expiration, there is less flow. To reduce this variation, one has to do the recording during end expiration after holding the breath when patient is awake, and on during surgery you can just disconnect the ventilator for a few seconds and just record it quickly. So these are the waves which are seen. Systole is equivalent to ventricular systole. Systolic wave, which is a forward wave, which is seen in opposite direction in transesophageal. This is transthoracic, followed by a smaller D, again forward flow, D wave, and then atrial contraction causing negative wave, okay, which is seen positive over here because of the probe position. Try to understand this. Let us come to pulmonary vein. Whatever I told you on hepatic, it is the same on pulmonary side. See, this is the ECG, this is the atrial tracing of A and B and X and Y. This AXVY is a very important concept. XY descent is equivalent to S2. S1 is atrial relaxation. Just after closing of valve, there is atria start relaxing. So this is due to atrial relaxation, which is very difficult to find on transthoracic, but in transesophageal you can very nicely see this wave. And then Y descent equivalent to another forward flow, that is D wave, followed by atrial reversal flow. Again, I have shown here that how this D wave, the diastole starts from here. The D wave corresponds to the forward flow across the mitral wall, that is E wave, followed by A wave, which is the corresponding wave for atrial contraction and atrial reversal. These two waves are very important because they are going to tell you many things about many pathologies. So on this side, on transthoracic echo, this is 4-chamber view, and see how beautiful this right lower pulmonary vein is draining into the left atrium. When you open the valve, aortic valve, that is 5-chamber view, what you see is right upper pulmonary vein. This is another view which I have come across and guided by American Society of Echocardiology, that in Sachs view, modified Sachs view, where you do see RVOT and aorta, and then right atrium and left atrium over here, you see beautiful flow of left lower pulmonary vein. Otherwise, left lower pulmonary vein is very difficult to see in transthoracic view. Coming to transesophageal view, this is, you all know this view, that this is atrial appendage, this is the ridge, Coumardian ridge, and then this is left upper pulmonary vein. And when you adjust the probe little bit, go inside and turn it few degrees, you know, you get this left lower pulmonary vein, and this is typical ulta V, that is opposite upside down V, you can see in the transesophageal view. Are you able to see my video over here? This is the 4-chamber view. Actually, I have turned the probe little bit to show you left superior pulmonary vein. Beautiful positive wave Fortunately, pulmonary vein in transthoracic as well as in transesophageal, both are towards the probe, so there is no confusion. Both are positive waves, red color. And see how beautifully in this another video you can see S1, S2, D and atrial reversal. And this is the image showing this V, opposite V pattern of these two veins. This is another patient which I came across. I could see, this is a bicaval view, and I have put the cursor near the behind the SVC. This is SVC and this is IVC behind the cursor where there is right upper pulmonary vein. So I could get, though it is not very ideal, but I could see S and D and atrial reversal. This is another important view in transthoracic, which is a crab view, which I told you a few minutes back. And this is aorta, this is right pulmonary artery, and this is the typical crab view. This is the crab, LA, and right superior pulmonary vein, right superior, right inferior, and left inferior pulmonary vein. And this is the color showing the same video.
Excuse me, madam.
Sorry? Yes?
Sorry, madam. I am sorry to disturb you.
Okay.
I am Dr. Kedar. I am not able to see your video at all.
Rajiv?
It is due
And the
to network
presentation
congestion
also
from
I
the
have
Dr.
not been
Kedar
able
side,
to
ma'am.
see.
Sorry? I'm able to see.
Kedar,
Sorry?
that is your internet problem mostly. We all can see.
Okay.
Should I disconnect and log in? I am sorry to disturb you all.
You can try that.
Dr. Kedar, it's totally
Okay,
depend
sir.
upon your network congestion. I request you just go to the open space where your phone having good internet network without any interruption, because all the videos are playing and we are able to see that. I request you. You just
Okay,
relog in 1
thank
second. Okay. Thank you,
you.
doctor.
Okay, thank you.
You can proceed, ma'am.
Yes. So this is the Sachs view, which I told you. This is a relatively new view. And luckily, 2 days back, I found it in one of the young patients, hypertensive. And this is the Sachs view showing aorta, RVOT. This is LA and this is left inferior pulmonary vein. This is the image and this is the beautiful SD and reversal pattern. So let's come to this. Now we will go through certain pathologies. I have divided this into systolic abnormalities and diastolic. In systolic, there is mitral regurg and tricuspid regurg we'll study, followed by systolic dysfunction. And in diastolic, atrial fibrillation, aortic valve stenosis, atrioventricular valve stenosis, that is tricuspid as well as mitral stenosis, diastolic dysfunction, and not to miss this constrictive pericarditis and restrictive cardiomyopathy. So coming to atrial fibrillation, there is absent atrial reversal wave, obviously, because atria just cannot, they are fibrillating, so they are not contracting powerfully, and there is no contribution of that 25 to 30% of blood going into the ventricle. So there is no relaxation also, and there is loss of S wave. In addition to that, there is small S wave. Okay. So here you, in this image, you can see small S wave followed by D wave, and there is no classic reversal wave of atria. This is one of the patients which is having atrial fibrillation as well as severe torrential TR. So there is systolic reversal also, and there is no A wave, and this irregularity you can obviously make out. Coming to tricuspid stenosis and mitral stenosis, this is with sinus rhythm. Because there is increased pressure in the atria because of stenosis, there is prominent atrial reversal, very obvious. So this is prominent atrial reversal. Try to understand this, and this is shown over here that because the big atria contract very powerfully against the stenotic valve. And in addition to that, this is very classic, that there is prolonged pressure half time of D wave or deceleration time, just like similar to deceleration time of E wave. because I told you that D wave is always coinciding with the E wave of the forward diastolic flow across the atrioventricular valve. So when you see pressure half time of this and you compare with this, both are prolonged. We all know this left ventricular diastolic dysfunction. In healthy, try to understand, in healthy individuals who are less than 40 years, S by D ratio, velocity of S and D ratio is less than 1 normally also, and it doesn't reflect high LA pressure. And why this is so? Because these young patients, not patients, young adults, they have powerful contraction of the LV, and there is tremendous pulling of valve towards the apex. So naturally, many a times S and D are less than 1. But if the patient is more than 40 years of age, see this you don't find in all the patients, but you do find sometimes AD is less than 1 and you are worried whether it is abnormal. No, it is not abnormal. Young healthy adults, they do exhibit this. And but when the adults become more than 40 years of age, usually the SD ratio is more than 1. That is very important. And you all know that this pulmonary venous flow, initially there is normal flow. In grade 1, S and D ratio is more than 1. Gradually, the S starts becoming less because of increased LA pressure, and reversal of atria start becoming more and more. We all know this, and this is very well explained many times. But what we have to understand is HEP-REF, that is the concept for describing hepatic failure, heart failure with reduced ejection fraction with high LA pressure. Usually, reduced ejection fraction is usually with high LA pressure, and S oblique D is always less than 1. There is prominent D wave which reflects high velocity transmitral E wave. I have been explaining you again and again, whenever there is prominent D wave, that means the flow across the mitral valve is also more during the initial E wave and rapid deceleration. This is very typical of HEP-REF with high LA pressure. But when you come to HEP-PEF, that is heart failure with preserved ejection fraction, which we come across commonly, and high LAP, let us discuss that. I just now told you that there is S by D less than 1 in HEP-REF with high LAP. But in HEP-PEF, that is preserved ejection fraction, S2 is well preserved. S2 is well preserved due to normal mitral annular motion, because LV is healthy still and contracting well. So there is no blunting of S wave. Thus, S oblique D is many a times more than 1, but that does not exclude high LAP. That is the important message I wanted to give you. So how do we go about it? Because many times we say, oh, S and D are okay, more than 1. So correlate clinically, of course, ask the patient whether he becomes breathless after exercise or climbing the stairs. But there is another method that is known as systolic fraction. That is simply VTI of S, VTI of D. You divide VTI of S by addition of VTI of S and D, and if it is more than 55%, with very high accuracy, one can say that the feeling pressure is normal. This is a very important concept, and I have seen many patients. I do these systolic fractions for almost every patient, and there is a difference, and I have correlated it with clinically. Patients do tell me that they are breathless when this fraction is less than 55%. Another important concept is left ventricular end diastolic pressure. That also one has to understand. Elevated left ventricular end diastolic pressure, that means earliest measurable marker of diastolic dysfunction. And it precedes increase in mean LAP. Increase in mean LAP takes little bit time to develop. So, but what is most important and very sensitive, that there is elevation of left ventricular end diastolic pressure. So how do we go about it? That we have to mitral valve A wave we have to see, and mitral valve and pulmonary vein A wave we have to see. So mitral valve A wave and pulmonary vein A wave are absolutely at the same time in normal patients. That is very accurate. It is very accurate and very sensitive method. But whenever there is elevated LVEDP, mitral valve closes before atrial relaxation has begun, because there is a rise in pressure in LV, and thus before LA pressure has decreased. What does that do? That is why there is more pronounced backward flow of blood into pulmonary veins, which causes wider A wave in pulmonary vein and then mitral valve A wave. So that is why we always say you measure the duration of A wave on mitral side and A wave in pulmonary vein side. So this difference, when it is more than 30 seconds, it predicts high LVEDP with reasonably high accuracy, and it is age independent and it is irrespective of EF. That is very important. And the less robust indicator of elevated LVEDP is increased velocity. That's why we tend to measure only this duration difference rather than the velocity, because it is less sensitive. There are many concepts and many understandings in this topic. So actually it is a big topic, but let me see how I explain this constrictive pericarditis, which is also very important topic. Why? Because even though tuberculosis is decreasing in incidence, radiation induced constriction is coming in a big way, and you all will agree with me that what is that known as operation we do for constrictive pericarditis? Decortication. Decortication is not at all easy operation. It is one of the most difficult operations. So if you assist surgeon in dealing with these operations through this pulmonary vein Doppler, hepatic vein Doppler, it will be a great help to him. So let us understand this physiology a bit. It's not very difficult. Just concentrate over here. See, these are 4 chambers, and this is the constriction behind around the heart. Just understand that SVC and pulmonary vein are not covered with pericardium. So naturally they are devoid of any changes due to constriction. That a very important concept one has to understand. But all other chambers, including IVC, they are constricted in this one cage, and there is increase in pressure, which is shown with red dots. Red dot means increase in pressure in all the chambers. So try to understand this concept, and then let us start with inspiration. Whenever there is inspiration, there is negative intrathoracic pressure, which is shown in pulmonary vein and SVC in constriction, but not, but all other chambers cannot reduce their pressure with inspiration. Try to understand this. So there is negative pressure in pulmonary vein, negative pressure in SVC with inspiration. Here already there is positive pressure, so there is no flow, less flow. Red is less flow and green is more flow. Try to understand this. So there is less flow across from pulmonary vein to left end. So consider on left side now. Left side there is less flow. Because there is less flow, another important concept in this is ventricular interdependence. Because it is caged in one solid constriction, the ventricles are absolutely interdependent. The moment one becomes big, the other has to become small. There is no room for expansion for the other one. That concept is very important. So whenever there is less flow on left side during inspiration, there is pulling of septum, because left ventricular cannot, it has to pull the other side. And because of this, what happens, there is a room in right ventricle. And there is already positive pressure over here. So there is more blood coming on the right side during inspiration. This is the crux of the whole pulmonary vein and hepatic vein Doppler, which we will see later on. And there is no flow from SVC to RA on inspiration. In expiration, exactly opposite things happen. I don't want to complicate the matter. Let us remember this. Okay, this is the patient with constriction. Are you able to see all the videos? Rajiv?
Yes, yes, we can.
Yes, sir. So this is the constriction. See, this is the beautiful septal bounce you are able to see. That is the hallmark of constriction. This is also this bounce you are able to see. This is constriction. This is solid, constriction around the heart. And this is the concept of ventricular interdependence, which I have explained you just now. And you all know that there is pulsus annulus reversus in these cases. What does that mean? That septal TDI, initial wave E prime, is more than the lateral E prime TDI. And why this is so? Usually, normally, lateral TDI E wave is E prime is more than S wave. We know because lateral is free to move, lateral part of the heart. But here, because of the constriction, lateral part moves less. So septum is shuddering, moving more. So naturally, E prime on septum is more than E prime on lateral. That is the hallmark of constriction. So now understand this slide. This will show you, see, this is inspiration. I'm explaining inspiration. What happens in aspiration? This is the hallmark during constriction, that there is reduction in D wave and reversal in expiration. From expiration to inspiration, here there is reversal of D wave. Okay. So in SVC, there is no effect. So there is inspiration causing decreased flow and expiration causing increased flow. Okay. On hepatic vein side, as I told you, there is reversal. D wave is many a times reverse. Here it is shown only, it has become small. But D wave reversal in expiration and prominent AR is the hallmark of constrictive, which it differentiates it from restrictive cardiomyopathy. And why one has to do all this jugglery? Because there are many similarities between restrictive and constrictive, but few differences which are important, and this is one of them, that diastolic reversal of D and prominent AR during expiration, because constriction is a treatable condition, whereas restriction you can't really do much. So if you miss restriction and constriction differentiation, you will probably, sometimes you may not treat that patient with decortication or anti-tubercular treatment. So that is the main crux of this slide. And on this side, there is increase in mitral flow variation, and on the right side, in mitral flow, there is reduction during inspiration, and on right side, there is increase. We all know that, and the difference is more than 40%. Coming to restrictive cardiomyopathy, this is a cardiac myocardial disease, where the myocardium is infiltrated with many things, eosinophilia and amyloidosis. There are many conditions, sarcoidosis, so many conditions are there. And there is increase in LV chamber stiffness, and there is rise in LA filling. So typically, what do you see in pulmonary vein Doppler? There is blunting of S wave. because there is rise in LAP. There is loss of S2 because of loss of longitudinal function of LV, because LV is also weak. Ejection fraction is also low in these cases. And elevated filling pressure. All these are responsible for blunting of S1. In addition to that, there is prominent D wave showing minimal respiratory variation and rapid deceleration time. Again, it is a sign of rise LAP. And prominent A reversal because of increased LAP. We all know that. On hepatic vein Doppler side, there is decrease in flow during inspiration as opposed to expiratory decrease in flow. This is the main, cardiologists, they discuss these things very in detail because there is always a dilemma whether it is restrictive or constrictive. So expiratory decrease in flows, that is the hallmark of constrictive pericarditis. Let us come to another concept, how these humble veins behave during mitral regurgitation. See, just follow this slide. In mild, whenever usually S is more than D, we all know that by now. Okay, so but even then there may be mild MR, there may be moderate MR, or there may be severe MR if it is associated with sinus rhythm, it is associated with normal ejection fraction because there is good descent of atrioventricular valve and there is no problem for atria to relax. Then there is normal or near normal LA pressure. It depends on compliance of left atrium. That is how one decides how these waves behave. Whenever there is reduction in S as compared to D, that is another situation. Here also the MR may be mild or moderate, provided it is associated with either atrial fibrillation. So naturally there is rise in LA pressure, so S is reduced. There is reduced ejection fraction, again the same basis behind this. High LA pressure because the atria are not compliant to accommodate that regurgitant flow. Again the same thing, poor LA compliance, and if it is associated with mitral stenosis. So naturally in these situations you do have S less than D, and of course with severe MR. But what I wanted to impress upon you is whenever there is systolic reversal in pulmonary vein, it is always severe MR. It is very sensitive, highly specific, but of course not very sensitive. And to increase the specificity further, what they advocate is that you do pulmonary vein Doppler at many places. Fortunately, there are 4 pulmonary veins, and in transesophageal it is very easy as compared to transthoracic. So when you do many separate pulmonary veins and show that there is reversal or there is S is less than D, then it is the specificity is increased. And another important thing is that each cardiac cycle you have to see this reversal. Why? If there is arrhythmia, which I have not included in this because it will be too much for today. Whenever there is arrhythmia, AV dissociation, you do see systolic reversal early, or you do see systolic reversal in idioventricular or junctional rhythm. So one has to differentiate it from severity of MR. Are you able to see this video? This is a case of mitral valve prolapse with moderate MR. See, there is considerable MR. LA is not yet dilated. And how I told you a few minutes back that S and D may be normal. So even though S and D ratio is normal, there is a moderate MR in this case. This is another case of AML and PML prolapse along with flail PML showing severe torrential MR. There is spontaneous PISA over here. The moment you see spontaneous PISA, it is a severe MR. This is the image of the same. And the same patient showing a prolapse as well as flail. In this is parasternal long axis, first view of the transthoracic. This is 4-chamber showing dilated LA. This LA must be more than 60 ml in volume. And beautifully, this slide is showing systolic, almost pansystolic reversal, and tall and with a fast deceleration time D wave. These humble vein, they are very useful whenever one is doing mitral valve repair, that is mitral clip insertion. If you do PV Doppler profile during this procedure, they have shown that low S and D TVI ratio. I just now told you that more than 55% is normal. If it is less than 0.7, that indicates recurrent MR. If you find after putting mitral clip during the procedure, if you think that this ratio is still not, sorry, this should not have been TVI, this should have been only S by D velocity ratio. When this is less than 0.7, it predicts recurrent MR, and it will predict long term outcome, which is not good. If she will, patient will develop MR again and again, or maybe on table you will see it. But if you see this reversal going to S by D less than 1, that is, just consider the previous slide, that severe reversal, then S less than D wave, becoming little better, or less S by D less than 1 becoming more than 1. This is the best predictor of outcome than your MR grading during the procedure. That is what they have come to conclusion with this. And there is survival benefit and lower rehospitalization rate. So this is very important from our point of view. Coming to regurgitation, again, this moderate tricuspid regurgitation will give you initially late systolic reversal, but if it is a torrential TR, it will certainly give you pansystolic reversal, which is shown over here, pansystolic. This is a case of bioprosthetic mitral valve restenosis, severe restenosis with torrential TR. This is hepatic vein, dilated IVC, dilated hepatic vein showing reversal of flow, that is in red. It should have been blue. Here you can see properly that the reversal of flow in the hepatic vein. And when I took the hepatic vein Doppler of this patient, this is the same patient I showed you a few minutes back, that there is irregularity, he is in atrial fibrillation, there is systolic reversal and blunting of D wave. This is another picture which I have taken from the same patient. This is the severe mitral stenosis with pulmonary hypertension. This is the transthoracic picture, and you can see in this hepatic vein, even at this gray scale also, you can see how these RBCs, I mean, the flow is reversing, okay? And this is the transesophageal view of hepatic vein. And this image is showing prominent reversal and systolic reversal also. Another case with torrential TR showing how the hepatic vein is getting reverse flow in red color. RV systolic dysfunction, again there is reduced S wave systolic phenomena, and in a severe case there is systolic reversal on hepatic vein Doppler. This is one or two slides, last two slides. This is a case of arithmogenic right ventricular dysplasia. It's a genetic disorder where there is dilated RA, dilated RV, RV systolic, diastolic failure, severe TR, and non-coopting because of the severe dilatation over here. There is non-cooption of the tricuspid valve. Look at this picture, that there is a very quiet flow across the tricuspid valve, even though there is severe TR, even though RA, RV are dilated. This is what I mean by low grade TR with right ventricular dysfunction. So whenever there is low grade TR and severe flow across the tricuspid valve, it is usually due to right ventricular systolic failure because pump is not able to generate enough pressure to push the blood across the valve. That is the meaning of it. You don't feel happy about it that, oh, it is non-turbulent, oh, it is very quiet, red and blue. No, it is failed ventricle. That is why it is showing this color. And again, this is showing the reversal. The same patient, how I told you about this non-competition, how this tricuspid valve, they are normal triad. So this is a functional TR and they are non-coopting with a little bit of pericardial effusion and systolic reversal. Last but not the least, when there is hepatic vein obstruction and it can happen post lung transplant or I don't know about heart transplant, I am not dealing with it, and liver parenchymal disease, there is no typical waveform in hepatic vein. So what you see is monophasic flow. There is no biphasic waveforms. That is what one has to remember. With lot of fatty liver and liver cirrhosis cases coming up, this is very important factor. That's all for today. Thanks a lot.
Thank you, Dr.
I'm
Sanjeevani, for
extremely
that.
sorry that I took extra time, but it was a,
No, no,
I,
don't feel sorry. It was worth it, and you have dealt with in detail about this humble vein, the pulmonary vein, the hepatic vein. There is a lot of science in it, how to interpret the waveforms and how to know what is normal and what is abnormal, and how to get clinical information from these waveforms. And the very well done. I think you have to do it once more sometime so that we can comprehend what all you said today. So the topic is open for discussion. Anybody wants to say anything? Anybody wants to?
Madam, what is good morning, sir? Good
Good
morning, sir.
morning. Good morning. Good morning.
Good morning, madam. It's
yes,
wonderful, nice presentation. What is the normal velocity of the hepatic blood flow? And you consider the IVC diameter for the this one?
yes. I didn't go into IVC diameter purposely because I wanted to concentrate on these uh, venous flow profiles more because IVC is again another topic which is important, of course. Whenever you see dilated IVC, you should do hepatic vein Doppler.
Hepatic.
It is, I had few videos with that, but because of time constraint, I didn't show it. Whenever in bicable view you see very big IVC, you just go down and do the hepatic vein Doppler. That is very important. The velocity is around 50 to 60 S wave and around 40. I may be wrong, a little bit variation over and there, but because machines keep giving us and we take the ratio. So D velocity is usually 40 centimeters.
Okay. And you told about mitral stenosis and all because
Hmm.
of the LA large,
Hmm.
so changes occurs. How about in patients with who are excessive tachycardia or exercised person? How the pattern behaves
Uh,
pulmonary?
of course, with tachycardia, LAP is going to go high, isn't it?
Hmm.
It is going to worse. The scenario is going to how in atrial fibrillation the scenario is worse because LAP is high.
In
So
exercise for
naturally,
athletes
it is
and all.
difficult to take Doppler in this situation. But you do get idea and you do see reversal. When you try to interrogate these veins, even in normal patients, you practice that way. That is how I have practiced it. I take it every day.
Okay.
So that you come to know what is abnormal. That is the way one has to practice. That is how we all are practicing. So and in transesophageal it is very easy.
Hmm.
And the flows are beautiful. S1 is
Can you explain once again, madam? You told the end systolic volume, left ventricular reflex by looking the
Okay, should
this
I go
one.
to the slide
No,
again?
just you explain. That's
Okay,
enough.
see, the thing is that the concept is that end diastolic volume is more, and because of that, the pressure across the left atrium and left ventricle is, they come close very fast.
Hmm.
So the ventricle pushes the mitral wall and it makes it close before atria has started relaxing. Understood?
Yes, ma'am.
So there is tremendous flow backwards. You understood? That is why you get more reverse.
Dr. Sanjeevani, I have one comment and one question.
Okay.
The comment is that the removal of constriction around the pericardium is probably better called as pericardiectomy,
Okay. Okay.
not decortication. That's one
Okay.
comment.
Okay.
And the question is, do you look at the portal vein pulsatility as well when you're looking at the hepatic veins?
Frankly speaking, the differentiation between portal vein, hepatic artery, and hepatic vein are very distinct on transthoracic. I have seen it on transthoracic. They are positive flows as against to hepatic vein, which is a negative flow. So number one, that they are red in transthoracic. I have not seen in transesophageal. You people would be doing it in a more frequently. And another thing is hepatic artery is pulsatile and red, and portal vein is monophasic and red. That is the difference.
Yeah. But now this current understanding is that portal vein pulsatility is indicative of RV failure.
Yes, they are coming with this concept and they are going still back and back, and they are, because these veins and are very thin walled, and they are connected to a low pressure chamber on the right side, that is RARV and pulmonary circulation. So they are in communication, and that is why beautiful, and because it is being a tube, small tube, it would show better velocity profiles than a chamber.
There is one question about can you differentiate constrictive pericarditis and restrictive cardiomyopathy? Somebody requested for repetition.
Okay. See, instead of going into all these jugglery, I will just tell you in very, very quick tip that in expiration, whenever there is positive pressure around the heart, already positive pressure is there in expiration, and because of ventricular interdependence, there is no space for ventricle to adjust beyond the pericardium. So there is D wave and D wave reversal in expiration. Actually, they say that's expiration to inspiration, going from expiration to inspiration, but they do say during expiration, and I have seen it that D wave reversal and prominent AR during expiration is the hallmark of constriction, and exactly opposite things happen in restriction. But this is one of the important differentiation, no doubt, but you do put don't take only this as a solo thing to diagnose. You do put TDI and restrictive cardiomyopathy being a myocardial disease, and in constriction their myocardium is normal, so the velocities of TDI are affected in restrictive. They are less, they are much less as compared to constriction. And annulus reversus, that is the velocities of tissue Doppler around the annulus, is reversed in constriction, because the lateral side of the ventricle cannot contract well because of the constriction. Very simple.
Madam, you said that age will going to change the reversal of the pulmonary flows. Is it so?
Sorry, come again.
Age, as the older age changes.
Yes.
Is it so,
Age,
madam?
because there is some amount of fibrosis occurring in the myocardium as age advances, diastolic dysfunction starts. Many times systolic dysfunction is there. So all these factors, many times it is not diagnosed, it is subtle. I mean, it is known as subclinic, one can say.
Okay. Thank you, madam.
There are two comments. One is excellent presentation and wonderful talk. You have to repeat it once more sometime later. Maybe we'll request you to do it once more.
Sure.
And there's one question on moderate MR causes flow reversal. Does moderate MR cause flow reversal is the question.
I told you, let me go to the slide because that explains in a better way.
Yeah.
Because I have been seeing these patients, you know. Let me go to the presentation mode. Are you able to see this slide now?
Yes.
Okay. See, whenever there is normal sinus rhythm, normal ejection fraction, near normal LA pressure, and good LA compliance, try to understand this scenario. But with mild and moderate MR. Okay. By you grade this MR with other parameters like vena contracta and you know, many other things. Even then the S may be more than D. That is normal. So normal SD ratio doesn't mean that the MR is small or negligible. That is what they want to say. And this normal SD ratio is because of these additional factors that patient is in sinus rhythm, there is normal EF, there is normal LA pressure and good LA compliance. Okay. But there are certain situations when patient is having mild to moderate MR, okay, but there is associated factor like atrial fibrillation, reduced ejection fraction, high LA pressure because LA is not compliant, poor LA compliance, or it is associated with mitral stenosis, which we come across in rheumatic scenario. Okay. So this condition, whenever it is associated with more than one, you will see S less than D. And what is important is that whenever there is complete systolic reversal, it is highly specific, though the sensitivity is low, highly specific of severe MR, highly specific systolic reversal. But patient should be in normal sinus rhythm because sometimes this arrhythmia is another different chapter which I could not include it because of time. But if patient is having atrioventricular dissociation or junctional rhythm, there is complete reversal in initial part. But late reversal and complete reversal is the hallmark of severe MR. I have shown you this case also. This is a moderate MR with normal S and D ratio. See, moderate. So this patient is having normal LA compliance. Okay. I think it is hand. Anything else? Did you understand? Am I able to answer your question? I don't know.
Yes, it is clear. It is clear. Thank you. And I don't see any more questions there. Anybody wants to make any comment or question? Last comment or last question? I would like to thank Dr. Sanjeevani and other participants for being with us today. And it was enlightening talk, of course. And there is a request for repeating the talk. So we will again schedule it sometime later, maybe next 3-4 weeks. Dr. Sanjeevani, thank you once again.
Yes, I would request all of you to practice these veins then before the next, so that you can contribute it more than me, you know. I want your contribution.
We will ask you more questions that time.
No, that is a. I mean, you are there to answer. When you are there, I have no problem.
Thank you so much. Thank you so much.
Thank you. Thank you.
Thank you. See you tomorrow and next Sunday. Thank you so much.